Welcome, everyone, and thank you for joining us for our webinar titled Cardiac PV Loop Data Analysis Tips and Tricks. This is Liam Sanyo, and I'm very pleased to be your host for today's event. This program was developed through a collaboration between the American Physiological Society and 80 Instruments in support of their shared mission to provide education and value to researchers everywhere. We have Dr. Adam Goodwill and Dr. Dwayne Townsend with us today, who will discuss the fundamentals of pressure-volume loop analysis as a means to study cardiac function. Adam, the floor is yours whenever you're ready.
Hi, Liam. Thanks for the introduction. Hi, everybody. Before I get started, I just want to take a minute to thank the American Physiological Society and 80 Instruments for putting this together. I also need to thank my daughter, Layla. So when I put my slides together, I hadn't actually considered that I wouldn't be able to point at the figures and that I'd be reliant on describing my figures through color. I am profoundly colorblind. So my 12-year-old was nice enough to sit down with me, go through Dad's slides, and put together a legend so that I know what colors I'm talking about, so I don't just refer to everything as that gray loop or this gray loop. So with that, let's go ahead and get started. So before we begin any discussion on pressure volume analysis, I think it's only right to acknowledge that the literature has been extensively informed of cardiac function under a variety of conditions using technologies that are independent of PV catheters. Now, Mary Lindsay put out a really excellent paper a few years back that reviewed the pros and cons of the various modalities for examining cardiac function in animal models, and a reference to that can be found beneath the table. One thing the manuscript does really well is that it highlights the two main non-PV modalities that are seen in use, which are echocardiography and cardiac MRI. Now, as with any tool, these modalities are going to have advantages and disadvantages. And what you find in common between the two is the ability to perform serial measurements and the ability to assess cardiac chamber structure. Echo is generally going to be more available and more portable than cardiac MRI. However, you get better blood tissue contrast from MRI as well as greater spatial resolution. Now, one particularly appealing aspect to echo is that it can be performed on conscious animals, but this comes with the notable caveat. And that caveat is that a significant acclimation needs to occur because the stress of the procedure would otherwise clearly introduce an experimental bias. Now, although each system has its own unique set of limitations, two that they hold in common and are arguably significant are that they both generally only capture data for short periods, and that the cardiac functional measures are largely load dependent. Now, I'm going to ask that you keep the notion of load dependence in mind because we're going to revisit that in a little bit. In the meantime, what we can take from this is that we have two useful tools in the tool chest, but an identifiable gap in the data that needs to be filled. So then why do we need PV loops? To answer that question, let's take a quick look at what a PV loop is and what it can tell us. So on the right-hand side of this slide, you see a textbook PV loop. Now, when I was first taught to acquire PV loops, I was told that it should look like a piece of toast. I've never understood that because bread and toast are the same shape, and so I always thought bread would be equally good, but I think so long as it looks vaguely like this, you're doing pretty well. Now this figure, or a notably similar one, is going to come second only to the Wiggers diagram and making professional and graduate students wonder whether they really want to understand the cardiovascular system. But the PV loop itself is actually a very basic concept. A single PV loop is the summation of the pressure and volume behavior that occurs within a single ventricle during a cardiac cycle. These figures are always presented with the ventricular volume on the x-axis and the ventricular pressure on the y-axis. For this example, we're going to look at the left ventricle. So if we begin at point C on the graph, you can see that we've just completed diastole. The ventricle is as full as it's ever going to get, and we're ready to begin systole. When the ventricle starts to contract, the mitral valve closes, and we're going to move on the diagram from C to D. Now, this is a generation of pressure without a change in volume, and so this is an isovolumetric contraction. When the pressure in the ventricle exceeds the pressure in the aortic valve is going to open, and we're going to begin our ejection phase. And this is where our line begins to move from D to F. As you can see, pressure is still being generated through the ejection phase until a peak systolic pressure that you find at point E. As the ventricle exhausts its capacity to contract and begins to relax, the pressure within the chamber is going to drop below that of the aorta. The aortic valve then closes. It's at this point that we've completed systole and begun diastole. We can therefore consider this to be our end systolic pressure volume point. So keep this particular point in your head. As the ventricle relaxes, but all valves are closed, pressure within the ventricle is going to drop at constant volume. So this is our isovolumetric relaxation. It'll continue until the pressure within the ventricle is less than that of the atrium, at which point the mitral valve is going to open and we're going to progress from points A to C. The ventricle is going to fill through diastole and we've managed to complete a single heartbeat. So fine, but what measures do we actually get from PV loops? Well, similar to echo and MRI, we're going to get end diastolic volumes and end systolic volumes. And from those volumes, we're going to be able to calculate stroke volume, ejection fraction, cardiac output. So we're going to get all the same volume information from a PV cath that we get from MRI or echo, but we're also going to get pressure information. Pmax and Pmin are immediately identifiable for each cardiac cycle. End systolic and end diastolic pressures are also identifiable with some very rudimentary shape analyses that can be accomplished by software. These last two metrics are particularly important as they're going to help us to address load-independent cardiac function. So please keep in mind that when I mention that we're interested in load-independent cardiac function, we don't lose the ability to obtain load-dependent measures simply because we can obtain load-independent measures. This slide shows a handful of commonly reported cardiac functional measures. Each of these are still recorded with PV loop analyses. Not only are they measured, but a benefit of PV approaches is that these values are continuously measured. With other modalities, you typically select short windows through the study, either to analyze or even to acquire your data. When working with a PV catheter, you get all load-dependent data for every cardiac cycle from the moment you complete your instrumentation until the end of the experiment. So what does that functionally mean? It functionally means two things. First of all, you get a staggering volume of data from every experiment. Now, often that data is quite frankly more than you need. Secondary to that, though, you remove the potential that you may miss out on an effect. So as an example, consider it from this perspective. If you are tasked with the assessment of two drugs, drug A and drug B, you may pick a particular time point in an acute study to assess outcomes and find that they achieve the same plateau effect. However, with PV work, you will immediately have access to the data needed to determine whether the rate at which they achieve the plateau is significantly different. So you've removed the potential for missing data simply by inadvertently introducing a bias. So we can get stroke work, DPDT max and min, contraction time and relaxation time, along with myriad other measures from the PV cath. We touch on these measures for a few reasons. First, they're measures that are commonly reported through the literature using numerous modalities. Second, they are all commonly associated with the term contractility. Now, the issue at play here is with ascribing a change in any of these measures to contractility, as all of these measures are load-dependent measures. Contractility is a load-independent phenomenon that we're going to discuss more in just a second. Now, you may notice that tau is highlighted in red, and the reason we've elected to single out tau is that it's often presented as a load-independent measure. However, literature exists indicating that tau is likely sensitive to changes in afterload. Where you fall on the range of the argument as to whether it is or is not sensitive to afterload is yours to debate, but the remaining measures have clearly been established to be load dependent. So we need to appreciate when a measure has load dependency, as that's going to provide us with insight as to whether an effect is a true change in contractility or if rather it's a Starling effect. So what is a Starling effect? Now this figure illustrates a classic Starling curve. To orient you to what we're looking at, the x-axis on these curves can vary, but it's intended to be some measure of ventricular preload. Typically, you see end diastolic volume or end diastolic pressure. The y-axis is a measure of external work. This is commonly stroke volume or cardiac output. For my money, I prefer stroke volume because cardiac output can easily be confounded by changes in heart rate. Now, keep in mind that preload is the amount of stretch that a ventricle experiences prior to a contraction. So we're basically looking at a length-tension relationship for an intact ventricle. Consistent with length-tension relationships seen in other tissues, there's an optimal degree of stretch, and with increased stretch, we will get increased force generation. And as you can see from the figure, if we move from our normal resting volume to the right on the graph, greater end diastolic volumes are associated with greater stroke volumes. When we move left from our resting value, lower end diastolic volumes are associated with lower stroke volumes. So the Frank-Starling law tells us that greater preload will result in a greater force of contraction. This is notably different from cardiac contractility. And the fact that the term contraction gets used, I think, is a lot of where the issue comes at play as to whether we're talking about force generation or true contractility. True contractility is the innate ability of the heart muscle to contract. Because it is the innate ability, contractility is force generation that is independent of stretch. So then how in a beating heart are we supposed to tease out load independent measures? So what you see here is the very process by which load independent measures can be obtained and ultimately assessed. The video on the left shows a pig's heart with an apically inserted pressure volume catheter. On the right, roughly synchronized, are pressure volume loops from that same heart. Now, you may note that the loops are getting smaller and shifting left with each successive cardiac cycle. That's because we're experimentally reducing preload by obstructing flow through the inferior vena cava. By doing this, we generate a series of loops from the same animal that each occur at a different level of ventricular stretch. In essence, by performing preload reductions, we are moving a heart to the left along its own Starling curve. In this figure, you can see the analytical potential opened up by performing preload reductions on a beating heart. Now, the panel on the left shows a series of loops obtained during a vena cava occlusion, similar to what was shown on the previous slide. Each loop will have its own unique end systolic point. We can use those individual end systolic points to identify the end systolic pressure-volume relationship of the heart. This relationship is a preload independent measure of cardiac contractile function and is therefore a measure of contractility. In health, the relationship is highly linear and contains two defining characteristics. The slope of the relationship is termed the end systolic elastance, or EES, and the x-axis intercept is termed the volume axis intercept, or V0. In the absence of a change in V0, a change in EES can be viewed as a change in contractility. So increases in slope relative to the control state reflect a positive inotropic response, and decreases in slope reflect a negative inotropic response. Now, there are times where V0 may change, and this is particularly true when comparing animals with some underlying cardiac structural abnormality to otherwise healthy controls. The fact that V0 has changed doesn't remove the ability to assess contractility. In circumstances where V0 is different, changes in the slope of EES can still be utilized as a metric of contractility. However, you need to employ more advanced statistical methods as you need to address the presence of covariance. So as with our end systolic pressure-volume relationship, we're also going to get end diastolic pressure-volume relationships during our preload reduction. We're going to touch on those briefly in a moment, and they're going to be discussed in greater depth by Dr. Townsend. But before we get to that, let's talk about why we should even care whether we're measuring changes in contractility or changes in Starling effects. So let's take a look at the effects of either changes in contractility or frank Starling-mediated changes in ventricular force generation on volume parameters. The graph on the left represents changes in inotropy, whereas the graph on the right reflects changes in preload. Note that all of the loops for the figure on the right fit a singular end systolic pressure-volume relationship, whereas there is a unique end systolic pressure-volume relationship for each of the loops on the left. To begin, let's only look at our purple control loops and our pink loops. In the figure on the left, you see that our pink loop demonstrates a steeper end systolic elastance, no real change in end diastolic volume, and a significant decrease in end systolic volume. Turning our attention to the figure on the right, the pink loop shows a constant end systolic elastance, relatively constant end systolic volume, and a significant increase in end diastolic volume. So very different responses between these two hearts. What can we get from this? Well, we can determine that values like ejection fraction, stroke volume, and if we assume a constant heart rate, cardiac output are going to be uninformative as to whether we're looking at inotropy or Starling effects, because we're seeing similar changes in those metrics in both hearts. We'd also find similar stroke work along with increased DPDT max and min in both conditions. If we were to reduce inotropy or preload, we would similarly confound the data, just in the opposite direction. So fundamentally, this is going to become important as it's going to provide insight into likely pathways that merit examination when studying response. Knowing whether an effect is inotropy or Starling informs you as to whether the response must be intrinsic to the myocardium. So although preload reduction is likely the most universally accepted way in which we determine load-independent contractility, that's not to say that you can't assess contractility without vena cava occlusions. But to do this, you need a sufficiently robust data set, which means you need to measure a sufficiently large number of cardiac cycles. Now, hopefully this figure looks familiar. This is the same Starling curve that we saw a few slides back, but this time you'll note that there's a second curve in orange. This orange curve demonstrates what a Starling curve would look like in the presence of sympathetic stimulation. In other words, this is a Starling curve showing the interplay of Starling effects and a positive inotrope. Because you're continuously collecting data with PV applications, you're able to potentially plot every single heartbeat from the experiment. If you assess Starling relationships across multiple conditions or perturbations, if you see a shift in the Starling relationship to greater stroke volumes at the same end diastolic volume, that is positive inotropy by definition. Stated a different way, an increase in stroke volume at constant end diastolic volume is the result of increased contractility. So just take a look at what you see there. We have our control line and our sympathetically stimulated line. On our control line, our normal resting value for end diastolic volume is somewhere around 120, we'll say, mils. And the stroke volume is somewhere below 50 mils. With the presence of sympathetic stimulation, despite the fact that end diastolic volume has remained constant at approximately 120 mils, our stroke volume is now greater than 50 mils. We are not moving along our Starling relationship. We have created an entirely new set point for our Starling relationships. Now, I've paid a lot of attention to the idea of contractility, but I think it's important to keep in mind that we also have end diastolic pressure volume relationships that are obtained in our PV analysis and through preload reductions. We obtain these in the same way and at the same time as end systolic pressure volume relationships. And although they tend to be slightly a different shape than ESPVR, their interpretation is fundamentally as straightforward. With decreased compliance, we would anticipate an upward shift in the end diastolic pressure volume relationship. And with increased compliance, we would expect a downward shift for any given EDV. In other words, with decreased compliance, which can also be thought of as increased ventricular stiffness, your end diastolic pressure will be higher than what is found in a typical heart for any given EDV. With increases in compliance or a less stiff ventricle, you'll find lower end diastolic pressures at any given end diastolic volume. And Dr. Townsend will expand upon this more during his portion of the webinar. Now, the interplay of end systolic pressure volume relationship and end diastolic pressure volume relationship is central to a potential analytical step that can inform you of the relative efficiency at which a heart is operating. And I honestly feel that this form of analysis is underutilized in the literature. Hopefully by this point, the PV loop looks pretty familiar and is readily identifiable. If we integrate the area of the loop itself, you get the stroke work for the heart. This is also termed the external work, and it can be thought of as being proportionate to the energy used to expel blood. If we examine that pseudo-triangular space bounded by the end systolic line of the PV loop, the end diastolic pressure volume relationship, and the end systolic pressure volume relationship, so the triangle to the left of the PV loop, you find the potential work. Now, this is the work of the heart that isn't converted to external work and can be thought of as the work of moving elastic elements within the heart, pumping calcium around, and so on. The summation of external and potential work is your pressure volume area. Now, this is the sum of all of the heart's work, and it's proportionate to your myocardial oxygen consumption. So in having performed your preload reduction, you've provided yourself with a data set to establish how much work the heart is doing and how efficiently it's performing that work. Increases in pressure volume area are going to come with accompanying increases in myocardial oxygen consumption, and decreases in pressure volume area will mean decreases in total myocardial oxygen consumption. If you compare two conditions that show similar pressure volume area, a condition that had a greater amount of external work performed per total pressure volume area, which can also be thought of as greater external work relative to potential work, would be a condition wherein more blood was being pumped for the same total energy. That is a more efficient heart. So to summarize my portion of the webinar, you get a staggering amount of data generated relating to numerous aspects of cardiac function in a reproducible fashion when you approach your questions using PV technologies. Now, one thing that is central to valuing any of these data is being sure there's a certain level of integrity to the measures you take. For that, I'm going to hand the reins over to Dr. Townsend, who can address some technical issues with acquiring PV data.
All right, thanks so much, Adam, for the fantastic presentation. And up next, I'm very pleased to welcome Dr. Dwayne Townsend, Associate Professor in the Department of Integrative Biology and Physiology at the University of Minnesota Medical School. Dwayne, thanks so much for joining us today, and feel free to start whenever you're ready.
All right. Well, I would like to also thank ADI Instruments and the American Physiological Society for bringing us all together, and to Insight Scientific for giving us the forum in which to do it. So I've been tasked with presenting sort of a more practical approach. What are some of the issues that I think are important when it comes to collecting high quality PV loop data? For the purposes of this talk, we will certainly we'll focus primarily on rodents, mouse data. We can certainly in the Q&A, we can talk about large animals. Both Adam and I have a bit of experience doing large animals, and we're going to talk mostly about small animals. All right, so sources of variability for PV loops. The big one that comes to mind is the surgical and anesthesia. This is often a challenge for PhD scientists who maybe haven't had a lot of surgical training and a lot of anesthetic training. Some of this is sort of surgery 101, but we're going to go through it. One thing about mice that you probably are aware of is they're pretty small. And when being small means that they don't have a lot of blood to lose. So even if you lose a fairly small amount, a few hundred microliters, it can become hemodynamically significant. When we're doing PV loops, I generally will not do them on mice that are smaller than 20 grams for a couple of reasons. One, the hearts are too small, but two, that they have so little blood volume that even the normal surgical procedures, you can end up losing a fair amount of volume, and that can be a hemodynamic problem when you're coming to measure your PV loops. So you have blood loss, which hopefully you can prevent in most cases by careful surgery and making sure you monitor you have your hemostasis intact using cautery or some other. I recommend cautery. That's what we use to make sure that any little bleeders get closed up as quickly as possible. So that's one potential mechanism of loss. Another, which is perhaps not as obvious, is the insensible fluid loss. So just through breathing, so whether the mouse is breathing on its own or whether you're ventilating it, what you're going to find is that there's a certain amount of volume lost over time. And that can become a not an inconsequential amount when we think about the length of the procedure. So for a normal PV loop experiment, you might run 45 minutes to an hour, and so that could lead to a loss of 4 to 5 mils of per kilogram of fluid. And of course, in a mouse, it's much smaller. The other thing is that when we expose the tissues, so when you open up the skin, you are going to introduce another mechanism for water to be lost. So that's another 2 to 3 mils per kilogram per hour. So this is something that we need to think about as we're looking at cardiovascular function. Is the overall volume of the circulatory system will be affected by these evaporative losses. So one of the things that I always do in my experiments, and I would recommend to you, is to give IV fluids. And so we use a 10% albumin in saline. It's a nice colloid, so it'll bring fluid into the circulatory system. So at baseline, I will give 5 mils per kg, just as sort of a bolus. It's sort of 10 minutes after we get things kind of instrumented and make sure the mouse isn't going to be moving around anymore. But if there's some blood loss, then I'll do more. I'll add more back. And so kind of a simple way to keep track of blood loss, we'll often use cotton-tipped applicators or Q-tips for hemostasis, to apply direct pressure to places where maybe we don't want to use cautery. And so if you get into a vessel or something, you have a little bit of a bleeder, you can kind of keep track of how much blood you've collected. So about one Q-tip is about 100 microliters. So if you start getting more than a couple of Q-tips going, you certainly need to replace that fluid. And this will also help in the reproducibility of your experiment. So as you increase the amount of fluid given, even if you're giving them too much fluid, they will generally auto-regulate that. They'll have increased urine output and things like that will help maintain your central venous pressures, you might think of it, how much blood you have in the mouse, which will then determine the preload within the heart. And so the closer you can get that preload to be consistent from mouse to mouse to mouse, the more consistent your data is, the more tighter your data will be, and the fewer animals you need to use to be able to identify any significant effects. Okay, so that's sort of basic surgery, fluid management and maintenance. These types of things are really important in the mouse because they're so small, and even small amounts of blood loss can have significant hemodynamic implications. There's a couple of other things that need to decide as you're getting ready to do these. The big one is the approach. How are we going to put this catheter into the heart? And there are essentially two ways to go about that. You can go in through the aorta, as shown here. And so this has some advantages, is that it's a closed chest approach, so you don't have to open up the chest to do it. So because the chest is closed, you don't have to ventilate. We'll talk a little bit later about why ventilation can be helpful and sometimes really useful in the analysis of the PV data, even with the carotid approach. So that is a bit of a caveat there. Some of the disadvantages of the carotid placement is that you're kind of limited in your ability to move it around. The aorta defines sort of where you're coming in and the angle at which you're coming in. And so it can be a little bit challenging if your catheter placement isn't quite right, or if you're sort of in the wrong angle, or you have something, occluding or crunching down on the catheter itself. That can be a problem. As Adam talked about a little bit, we have to alter preload. One of the sort of gold standard ways of doing that is to occlude the inferior vena cava as it's coming back up to the heart. In order to do that in the carotid approach, you have to do another incision. So you have to do another laparotomy, assuming you don't want to open the chest. So to get access to that vena cava, which can also be a little bit challenging, and sometimes your occlusions aren't as good as you'd like them to be. The other thing that is an issue in, especially in smaller hearts, is this idea of outflow tract obstruction. We came across this problem when we were looking at we had a transgenic mouse, and the transgene, for whatever reason, resulted in the mouse having a relatively smaller heart. And what we noticed is that there were some significant differences in the hemodynamics, especially the stroke volume and the end-diastolic volumes of hearts that we were doing where we came in through the carotid or through the aorta, and hearts we did through the apical approach, which we'll talk about next. And what we found is that even some of these smaller hearts, we were getting what appears to be a significant amount of outflow tract obstruction by the catheter itself as it comes down through the aorta. And so I've shown here this little figure on the left here, images of aortic sizes. So of sort of a relatively robust mouse will have an aortic diameter of about 1.2 to 2 millimeters. And so these catheters, whichever catheter you're using, so I have the 1.4 French, which is sort of the classic molar size, the 1.2 French, which is the transonic, their catheter size, and then Millar has a 1 French catheter as well. So you could kind of see their relative sizes and how that could implicate things. So in the large vessel, maybe it's not such a big deal, but in the small aorta, where it's down in the 0.8 millimeter range, it can be a significant issue. And so it's something to keep in mind as you're making the decisions about how you want to approach the insertion of the catheter within the ventricle. Okay, so that's sort of the carotid approach. It has some pluses and some minuses, as with every approach, I think you'll find. All right, so talking about the apical approach. So the apical approach, so the advantages here is that you can really optimize the placement. You can make sure that the catheter is right in the middle of the ventricle, so you're getting good data, good volume measurements on both sides. You don't have to worry about outflow tract obstructions because it's not in the outflow tract. You don't have to do an additional surgery for the vena cava occlusions because if you're already in the chest, the vena cava is running right through the chest. It's really easy to occlude it as it's going right past the heart. But there are some disadvantages. So one is, of course, it requires ventilation because you're in the chest. And so that's required for this approach. But as I mentioned, it's not required for the carotid approach, but I think it's often a good idea. Not only because it really keeps the animal healthier too, and I think that healthy animal will give you much better data than a poorly anesthetized animal. So there's extensive surgical manipulation with the apical approach, right? We're opening up the chest. We have to modify a big bunch of the chest wall in order to get good access to the heart, to be able to see it. And there's also the potential that you actually could injure the heart. You're cutting across the chest wall. The heart is right underneath there. And so that can be problematic. And so a lot of the learning curve is how do I avoid damaging the heart coming in with the apical approach. So these are sort of a couple of different approaches that people take. They have their pluses and their minuses, and you'll find them both well represented in the literature. So the next little bit here, I'm going to talk about one of the common artifacts that we see, especially in the mouse, and this is because the mouse has a really small heart, and there's a lot of stuff in there. And so when you insert your catheter, so I've shown the apical approach here over on the right. What can sometimes happen is you'll have a band, it could be a papillary muscle or a chordae tendineae or something that really just stretches right across the pressure transducer on your catheter. And so what happens in this case is that you'll get a pressure tracing that looks a little like this in the middle here, where it'll be a relatively normal pressure tracing. There's a little flat period, and then there's this big spike. And so that big spike right at the end of systole, what's happening is that there's some internal cardiac structure is actually compressing the force transducer. So you're not actually measuring ventricular pressure anymore. You're measuring how well this thing is squeezing on your force transducer. And you'll see that in your PV loops with this sort of end systolic spike, as you can see over here on the left. And so this is a bit of a problem. If you're fortunate and it's happening very early on, you can readjust your catheter position to avoid it. And so it depends on your approach. If you're using apical, sometimes on the aortic approach, it's really hard to get it out from underneath there if the aorta dumps you right under a papillary muscle. But with the apical approach, you can sometimes sort of twist your catheter, change the angle a little bit to try to avoid these papillary muscles or whatever it is that's in there that's causing this dilemma. Unfortunately, usually it's not even present at baseline. You'll have a beautiful PV loop going in, and then when you increase contractility with, if you're giving dobutamine, for example, to accelerate the amount of contraction to assess what can this heart do, that's when it'll often show up as the heart becomes very contraction, you'll have almost an entire ablation of the ventricle as you stimulate the contractility of that heart. And so then that's when this will become a problem. And so at that point, for generally once you get a catheter in, if you move it, it gets really hard to change or to compare the volumes before you moved it to after you moved it, because the dynamics of its interaction with the wall will change. Usually depending on your catheter, sort of the theory behind your catheter, you determine the component that is the wall. The ventricular wall contributes a certain amount to the volume, but that is very dependent on catheter positioning. And so you don't want to be moving your catheter within your experiment. So once you have it in there, you kind of want to live with that position. But sometimes you'll end up with this situation where you have to then go back and identify what is my real systolic pressure. And so if you were to measure your systolic pressure in the aorta, for example, you would, in this plot on the left here, you'd see that the aortic pressures would be somewhere around 100. And so that's your real systolic pressure. And then it gets really challenging to deal with the end diastolic and systolic pressure volume relationship, because this is going to, as you decrease contractility by decreasing preload, this spike will go away because you're no longer compressing down on your catheter. So that makes it really challenging to deal with that measurement. For that reason, I'll often use the preload recruitable stroke work as a measure. So you look at the stroke work, which is the area, as Adam described, inside the PV loop, and how that changes with changes in preload, to get around some of those issues with these spikes. And some of the software analysis systems available are actually designed to sort of recognize these types of spikes and will avoid them. So it's a common, at least I find it common, sort of artifact of signaling that has to do with a sort of surgical approach. All right, so the next thing I wanted to touch upon was this notion of respiratory artifacts. So we're usually, when I'm using an open chest model mostly. And so when we have positive pressure ventilation, and this changes the preload on the left ventricle. And you can see it a little bit down here in the upper tracing on the right. You can see how preload is changing ever subtly, and that small little change in preload results in this shift in systolic pressures that you're seeing on the top side. So the change in preload is what's driving that. And so that makes it really hard to know, okay, what's the heart really doing here? And so if you want to measure your steady state measurements, it can be challenging when you have all of this up and down business. And so one of the things that's really helpful is to sort of turn ventilation off for a little bit. And so you can induce a period of apnea. Most ventilators will have a little sigh button or something where you can just turn it off for a little bit. And so that's what we do. So for just a couple of seconds, we turn it off, and that allows us to get contractile data in the absence of that respiratory artifact. And so that allows us to have a series of multiple data sets or multiple contractions in which we can analyze and take the average of the stroke volumes, the derivatives, the pressures, and all of those things that are you can get from these steady state measurements. And while that's nice, it's almost essential to be able to do it during the IVC occlusions. And so when you're doing an IVC occlusion, you really you're trying to control your preload, right? And the last thing you need is your ventilator coming in and pushing more blood, or if the animal has a closed chest, they start breathing or continue breathing, and that can really cause issues when you're trying to control when the preload is, that as you're dropping your preload, if you have respiratory artifacts on top of that, it can sort of takes the decline in this pressure away. And so you'll end up with spikes and things inside there that make it hard to analyze at the end of the day. So that's one reason I really like ventilating, even with the closed chest, is because it allows you to make sure they're breathing, make sure they're well ventilated, so that when you turn this off, they don't start gasping. That's an important feature. But it gives you that control, that ability to sort of turn them off and make sure that you can control their respirations and get that data that you need to get, instead of having to do multiple occlusions. All right, now we talked a lot about occlusions, and so we want to spend a little bit of time sort of thinking about how we do them. And in the rodent, it's a little bit different than large animals. So in large animals, there's a fair amount of sort of systolic reserve, you might call it, that, you know, they're when you occlude their diastolic, when you include their IVC or the preload, there'll be a nice broad period where the end diastolic volume can drop and pressures are relatively maintained. I mean, they're coming down, but you don't run into any sort of catastrophic losses. What happens in the mouse, which you can see in the PV loop on the right side with the red and the black. If you look at the black for the moment here, you can sort of follow it along as it begins relatively full, and then as we're decreasing the IVC return, you can see that the end diastolic volume starts to decline to a point. And then it stops declining. And then what starts to happen is that you just start, the whole loop just actually starts to shrink. And what's happening there is that as you get down below, 50 or 75 millimeters of mercury, you start limiting perfusion to the heart. And so then what happens is that that you'll get this sort of curvilinear response. And that last little bit is really, you're just starving the heart. And so that can be a little bit problematic when you're trying to assess what the contractility is. Because if you just basically go in and you put the catheter in and it drops like a stone, you're not going to know, is that really the end diastolic systolic relationship, or is it just an artifact of the fact that my pressures were already a little on the low side and now I've sort of pushed them over the edge? So one way to sort of think about pressure volume loops, or think about preload, is to look at the two ventricles simultaneously. And so that's what we've done here in this lower tracing. So in red, we have the RV pressure. So we have put a pressure catheter within the RV, and simultaneously we had a catheter in the LV. And you can see that when we do the IVC occlusion, right around the beginning of this red arrow, you can see that it starts to drop in the right ventricle almost immediately, which makes sense, right? Because that's where the blood is returning to. And that there's a little bit of delay, and then you'll start seeing this decline in the left ventricle. So by looking at this, you can kind of get a sense where there's 4 or 5 beats between when you occlude the IVC to when you start seeing this decline. Now, as I mentioned, that there's a relatively limited volume available in the mouse. So as you start occluding, it'll come down a little bit and then it'll just sort of drop. And that's not great for identifying changes in contractility. So one of the things that we do in our group is that when we want to alter preload, we do it in both directions. So we can alter preload or altering loading really, by doing the IVC, which we've seen, and that works really well in large animals, and you can get data from mouse models as well. But the other thing that we do is after we do the IVC, we wait a little while, and then we'll do what is essentially an abdominal compression, where you just take a couple fingers and you just push down on the abdomen of the mouse. And what that does is it does 2 things. One is that it increases the preload, so you're actually squeezing a little bit of blood back in, and so you'll see that as a small increase in the right ventricular pressure. But it also increases afterload on the left ventricle, because you're actually pressing down on the abdominal aorta as it's coming down through the body. And so when you do that, you increase the afterload on the left ventricle, and that will also result in an expansion of the ventricle. So you'll get a larger amount of ventricle available to you. And so you can see that again on this middle PV loop on the right side of the figure here. These loops in red are from the abdominal compression. So when we compress them, you can see you can get a much larger volume exposure of the end diastolic volume. So that gives you a much larger range, which comes in handy if you're interested in understanding some of the passive dynamic properties of the heart, which may not be present in the below baseline PV loop data. Okay. And so we can think about this a little bit. This is, again, looking at the passive properties of the heart. And so this is really an interesting point of research as we're trying to understand heart failure with preserved ejection fraction, these types of the idea of diastolic heart failure, what is going on with these mice and how are they coupling to the vasculature. So in a mouse, so this is our baseline data where we find that, at least in our data sets, a linear end diastolic volume and diastolic pressure relationship is fit pretty well with a linear model. And so you can see this is a useful model at baseline, and then we add a little bit of dobutamine, and you can start to see this shifting of the slope. So it's becoming less steep. So the ventricle is becoming more compliant as you increase the amount of dobutamine that we're seeing here. And so this is a useful measure to be able to assess sort of the dynamic nature in which the ventricles are filling in response to stimulation or other perturbations. So if you have a genetic model, for example, or some other model that you might want to understand, what is the passive properties of the heart? And so that this will be a relatively straightforward way to do that. But by doing those abdominal compressions, you can extend the area in which you can perform this analysis, which will give you a better understanding of what that ventricle is doing and what it looks like. All right. So some other analysis issues as you're preparing your protocols and thinking about how you're going to do this is to make sure that after you do your IVC occlusions is that you wait a while before you redo anything, before you collect any other measurements. And so the reason for this is that when you do the IVC, you're going to drop systemic blood pressure. And when you drop systemic blood pressure, you activate the baroreceptor reflexes, which is going to increase the sympathetic nervous system output to the heart. And so if you're taking other measurements right after that, they'll be skewed, right? Because you'll have endogenous sympathetic activation on top of whatever you have going on. And you can see this if you take your data set and you measure the end systolic volume pressure relationship while you're going down versus that same heart that next second as it's coming back up. The end systolic and diastolic pressure volume relationship is much steeper as you're coming back up. And a good part of that is because you have an increase in sympathetic activity coming into the heart. Similarly with the abdominal compression, if you've got a lot of sympathetic tone, when you do the abdominal compression, you're going to send this pulse of high pressure up into the baroreceptors, and they're going to sort of withdraw a sympathetic tone for a little bit. So anytime you modulate preload, make sure you wait a little while for it to stabilize before you do any steady state measurements. In fact, I always do my steady state measurements before I do my IVCs for this very reason. The other big issue is loop rejection. And so nobody ever likes to throw data away. But sometimes there are data, you'll have an arrhythmic beat, a PVC or something that will really just skew your data. It starts beating when it's only half full or something ridiculous like that. And so those data really don't help you understand what's going on in the heart on average. And you really want to remove them. It's really a big issue in the IVC occlusions as you're coming down, where one or two loops could really distort the entire image of what that what that heart looked like. So that's another thing. This is where sort of maintaining our data integrity becomes important. So if you're going to be throwing out loops, you need to make sure you note which loops you're throwing out, make sure they're recorded. And this is really just to preserve the integrity of the data workflow. It's a huge issue in industry where the FDA is going to want to look at all your preclinical data, and if you're throwing out loops, that could be a big problem. But if you can really identify, okay, here's why we threw this loop out, that will placate them to some degree. Right. So that's basically all I have, and I think we have a few more questions. We ask you a few questions, and then we will come back and we'll address some of your questions. So if you have any questions, now is the time to throw them over into the Ask a Question box, and I'll turn it back to Liam.
Excellent. All right, moving right on to the Q&A session. And as a reminder, if you do have a question for us, please submit it using the Ask a Question box beside the media player. All right, so let's jump right in, and we're going to kick things off with a few questions that came in from registration. First one being, what are the most important parameters which I have to pay attention to during data recording with animals and data processing? And Dwayne, maybe I'll direct this one to you first.
Yeah, so one thing that I didn't mention, but is really important, is temperature. So maintaining core body temperature, especially in the mouse, is a huge issue. So that's number one thing to watch. Number two thing to watch is it's kind of a combination between heart rate and blood pressure to kind of get a sense for how the mouse is doing. Those are the heart rate I watch pretty closely, and then the positive derivative is another thing that I'll watch during the recording to kind of see how they're doing, and it depends a little bit on the analysis system you have, but I like to watch the trends. And so once you get it kind of instrumented, and as I mentioned, I have there's a fluid loading portion of my protocols. So during that period, I'm watching them very carefully to make sure that they're not decompensating, or there's not some other issue that might be playing a role. Looking for bleeding somewhere that I might be able to do something about. Those are all things that are useful to monitor as you're doing this preparation.
All right, great answer. And Adam, do you have anything to add on to that?
I think the only thing that I would add is that, to be quite honest, a lot of that answer focused on small animal, and my experience with large animal would say that you really need to be diligent about the same things in large animal. I think a lot of times we write off temperature regulation, in particular in large animals, and just assume that if you have a pig or dog on the table, it's going to stay plenty warm, and that's quite simply not the case. Hemodynamic stability, all the very same factors I think are translatable across pretty much any model you'd work in.
Excellent. All right, thanks. And we actually do have David and Brenton here from the AD Instruments team. David or Brenton, what's your perspective on this?
Yeah, hello everybody. This is Brenton from AD Instruments. I just wanted to highlight that all of these tips and tricks, there are different tools that our support and our sales team can walk through that allow the visualization to make sure that the temperature, heart rate, blood pressure, all of these items are visualized and accurately captured, and allowing you to really keep the animal performing well.
All right, perfect. And it looks like we are nearing the top of the hour, but we do want to answer a few more of our questions. So if you can join us for a little while longer, thanks so much. And if not, feel free to move on to your next meeting of the day. But a few people here have asked about anesthesia. And so how does anesthesia affect PV loops in different animal models or strains? And do you have a preferred anesthetic? What is the composition to mitigate depression of cardiovascular function? And so, Adam, I know you measure PV loops in a few different animal models. What's your experience with this?
So almost always when we're measuring pressure volume relationships, we're using a combination of alpha chlorelose and morphine. And we've relied on that. It's not as common as inhaled anesthetics by any means, and it's only appropriate for acute use. So it would have to be for a terminal procedure. But the advantage of the alpha chlorelose morphine mixture is that it really provides pretty impressive hemodynamic stability, doesn't have significant effects on pressure responses. And so we find that you end up with an animal that remains stable for a much longer period than you would on, say, isoflurane or sevoflurane.
All right, great answer.
So,
And Dwayne, sorry.
So on the mouse front, so I'm not a big fan of injectables in mice just because it's so hard to go backwards and it's so easy to overdose them. So we use inhalants almost exclusively, so isoflurane. And one of the tricks we use to sort of minimize the cardiodepressive effects of the inhalants is that we'll use a two-stage anesthetic protocol. So once we induce them, we'll then step down to about 2%. That's where we maintain them, and it depends from system to system. So you kind of have to play it a little bit by ear or eye, whatever, to see how your animals respond to your system. But in our system, we do all of our surgical manipulations at 2%. And then once we get the catheter in and the animal's instrumented and relatively stable, then we'll actually turn them down. And so we'll put them into I like to think of it as a really deep sedation. We couldn't do any additional surgical manipulations because they would start twitching and they'd feel that, but they're okay just kind of hanging out there. And we find that by sort of backing off the anesthetic, we can see a recovery of some of the hemodynamic function, and it gives a reasonably good.
Dwayne, you're just breaking up a bit. I'm just going to call you on the phone line here. And as we reconnect, Dwayne, maybe just move on to the next question. How important is accurate determination of V0? So Adam, maybe we could start with you.
Sure. So when we talked about end-systolic pressure volume relationships, we broke it down into end-systolic elastance and V0. And the thing about it is that you draw the line, or the software realistically draws the line based on the series of end-systolic pressure volume relationships. So the quality of your IVC occlusion, the quality of your preload reduction is going to determine both sort of the straightness of your line as well as the accuracy of your V0. So to get an accurate V0, you want to make sure that you have high quality occlusions, that you're actually sampling across an appropriate number of cardiac cycles. And as Dwayne touched on, that you are accounting for anomalies that occur. Now, the reason it becomes important to have an accurate V0 is to make sure that your interpretation of EES is appropriate. So Burkhoff and Suga have both published papers talking about how if V0 changes, there are theoretical situations under which something may look like contractility, but may not be contractility simply because of that shift in V0. Now, V0 can change. You just have to do analysis for covariance to make sure that you're accounting for the fact that both EES and V0 are changing. So I would say it's actually pretty important to make sure that you're confident in your V0 value, simply to make sure that the next step that you're making is the right step. But to be confident in the V0 value, it all comes down to being confident in that preload reduction that you performed.
Excellent. Thanks, Adam. And Dwayne, are you back with us here?
I think so.
Excellent. Yeah, perfect.
I'm always with me. So in the issue with the V0 in rodents, it gets to that point where we talked about how at some point you actually start just shrinking your curves rather than them shifting down, and that it may be playing a role in the degree of you're just starving the heart, and so contractility and contraction is reducing because it's not getting perfused sufficiently. which is different than having a difference in contractility. And so your V naught, if it's stable, you know, okay, that's probably not happening. But if that's moving around, you may have to look at what's happening during those occlusions. Am I really decreasing preload and seeing a reduction in contractility in response to that? Or am I maybe a little bit of reducing preload, but then also a reduction in perfusion pressures, which are then resulting in a decline in function?
All right, fantastic. And I think in the interest of time, we'll just make this next question the last one. But how reliable is this technology versus echo or other technologies? And so, Dwayne, what do you think about this one?
So, you know, it depends what you mean by reliability. So if you are, in almost all of our study designs, we're rarely actually comparing, you know, PV volume data to echo data, right? And so if you get a stroke volume from the echo, it's probably not going to be the same as the stroke volume that you get from your PV data, even from the same mice. It should be in the ballpark. But what really you need to compare your controls with the same modality. So you've got a control mouse and then a transgenic mouse, or you've got a control period and then you give a drug and your treated period. So from that range, if there's no effect, your volume will change. Your parameters will stay the same across the treated and untreated versions within the PV setting. As Adam talked about, echo has some advantages, the ability to follow the same animal serially, but the big downfall is it doesn't have any real pressure measure, and so you have a difficult time assessing how much pressure is being generated and how much of that pressure is because of load dependent issues. And so that sort of becomes the question is it reliable in that you can, yes, if you're fastidious about your surgical approach and your anesthesia and your maintenance and your monitoring and all of that, you can get highly reliable, repeatable data out of pressure volume loops. There are a lot of little steps that you got to pay attention to, as we've spent the last hour talking about, but those are all when they come together, you can get very, very nice and repeatable data. When you compare the absolute volumes, there's a lot of different assumptions that are made. So the assumptions that echoes make, is you've got that one or two beats that you're looking at, and you can define aspects of the ventricular wall, but there's assumptions that are made. Just like the PV loop assumes that the ventricle is a cylinder, right? And so when it's not a cylinder, then it'll be off by a little bit. And I think there's been a couple of other webinars on sort of the understanding some of these differences in the pressure volume loops. I mean, you can check up in the resource tabs. I think you'll find some useful information there as well. Adam,
all right, fantastic answer. And Adam, anything to add on to that about the reliability of PV loops versus other technologies, other alternatives like echo?
So I'm in the same boat as Dwayne on this one. We don't make it a practice of in the lab trying to measure the same metrics by multiple modalities. I think there is a robust body of literature out there from folks who have made the effort to cross-validate, and I think Dwayne's absolutely right. You'll never get it'd be shocking to ever find a circumstance where you were consistently getting exactly identical values between multiple modalities, because everything, as he said, builds on assumptions. As an anecdote in our hands, we try to keep busy, and PV is a big part of the research that we do. And one of the questions that we've sort of asked ourselves through the years is, if we look back through our historic controls, are we seeing similar values? Because we've changed numerous catheters through the years, obviously, because over time they just wear down and break. We've upgraded our software from time to time, and going back and sort of looking through historic data over 10 or so years of pressure volume acquisition, we get basically, if we account for, that we're looking only at animals of the same age and the same size and the same condition, we find that we typically get pretty comparable end-diastolic volumes and end-systolic volumes. So with regards to reproducibility, in our hands, it's been really high, and we've been extremely pleased with the technology.
Excellent. All right, and I think I'll give the last word to the ADI team. Brenton and David, what's your perspective on this one?
I wanted to echo what I heard from both Adam and Dwayne in the volume of literature that does back this technology up. Additional tools that specifically speaking towards 80 instruments and LabChart, there are ways that you can sort of mesh echo with PV loop if your protocol would choose to go that route through echo volume fit. So it's certainly stuff that if it's information you want to talk about, I invite anybody to contact us through the information that you see on your screen, and we'll be happy to talk about how this impacts your research. So.
All right, thanks so much. So thank you so much, Adam and Dwayne, for all your fantastic insights today, both for your presentations as well as the Q&A session. And thanks also, Brenton and David, for joining us for the Q&A.
Thanks for having us.
Yeah, thanks. This was really great. And thank you, everyone who attended, for taking an hour out of your day for us.
Thanks so much, everyone, for joining us today, a little past the hour to attend the webinar. We hope that you found the information presented both educational and applicable to your research. And of course, a very big thank you to 80 Instruments for sponsoring the event. Again, the slides and a recording of today's webinar will be available soon at insidescientific.com, and a transcribed report of the Q&A session will be posted in the coming weeks, along with answers to all the questions that we were unable to address today. So look out for an email or two regarding these resources in the near future. Finally, you will be moved to a survey, which should pop up on your screen, and we invite you to please take a moment to provide your feedback and let us know what webinar topics you'd like to see in the future to ensure that these events are applicable to your research. And so in closing, thank you again for taking part in this American Physiological Society webinar, and we look forward to having you with us again soon.